Welcome to the deep dive. Today, we're tackling a big one for MSRA revision, Hodgkin's lymphoma.
That's right. It definitely comes up, so having a solid grasp is crucial.
Absolutely. So if Hodgkin's is on your study list, and honestly, it should be, you're definitely in the right place,
hmm
we're going to really cut through the detail and pull out the absolute core knowledge you need.
Exactly. Think of this as your kind of high-yield summary. We've sifted through the revision
Yeah.
notes, pulled out the essentials, the stuff that needs to stick for the exam.
Efficiency and clarity, that's the mission.
Spot on.
Okay, let's get straight into it then. What exactly is Hodgkin's lymphoma? How do we define it?
So Hodgkin's lymphoma, or HHL, it's a type of cancer, specifically a cancer of the lymphatic system.
Okay.
And the absolute key thing, the hallmark feature, is the presence of these specific abnormal cells called Reed-Sternberg cells.
Reed-Sternberg cells, right?
You find them within the lymph nodes. If Reed-Sternberg cells are mentioned, you should immediately be thinking Hodgkin's.
Got it. The key identifier. What's so special about them? Why are they the defining feature?
Well, they're these large, quite atypical-looking cells. They come about because of a malignant proliferation, basically an uncontrolled growth, of B-line lymphocytes.
B cells gone wrong, essentially.
Exactly. And interestingly, HL has this bimodal age distribution,
Bimodal, meaning
meaning it tends to peak in two distinct age groups. First in young adults, say between 15 and 40 years old,
okay.
and then again in older adults, usually over 50.
Yeah.
It's also slightly more common in men,
Right, two peaks. Young adults and over 50s. Useful demographic clue.
definitely.
Yeah.
And that definitive diagnosis, it absolutely relies on finding those Reed-Sternberg cells in a lymph node biopsy.
So you need that tissue sample. Under the microscope, what are we looking for?
Histologically, yeah, you'd see those characteristic large Reed-Sternberg cells. They're often multinucleated, meaning they have more than one nucleus.
Okay.
And they're typically sitting amongst a background of smaller lymphocytes, which are also B-cell derived, along with other inflammatory cells.
And is it all just one type, or are there variations?
Good question. Classification is important here. We mainly talk about classical Hodgkin's lymphoma.
Classical HL.
Yep. And that has four main subtypes. There's nodular sclerosis. That's often the most common one you'll encounter. Then mixed cellularity, lymphocyte-rich, and lymphocyte-depleted.
4 subtypes under classical.
But there's also another distinct type called Nodular Lymphocyte Predominant Hodgkin's lymphoma, or NLPHL.
NLPHL. How's that different?
Well, the key difference is that NLPHL usually lacks those classic Reed-Sternberg cells. Instead, it has different abnormal cells, sometimes called popcorn cells.
No Reed-Sternberg cells in NLPHL. That seems important.
It is. And NLPHL also carries a slightly higher risk over time of transforming into a type of high-grade non-Hodgkin's lymphoma.
Okay, so Reed-Sternberg usually means classical. Absence points towards NLPHL, which has that transformation risk. Good distinction to remember.
Precisely.
So what actually causes this? What kicks off the development of Hodgkin's lymphoma? What's the etiology?
Well, the honest answer is the exact cause isn't fully known.
Ah, okay. Not uncommon in medicine.
No, indeed. The current thinking is that it's likely multifactorial.
Multifactorial, meaning a mix of things.
Exactly. Probably a combination of genetic predisposition, environmental factors, and how the individual's immune system functions.
Any specific factors that stand out?
Yes, there's a pretty strong link, particularly in some types of HL, with viral infections, especially the Epstein-Barr virus, EBV.
EBV, the glandular fever virus?
That's the one. In fact, EBV genetic material can be found inside the Reed-Sternberg cells in about 50%, so half, of patients with classical HL.
Wow, 50%. That's significant.
It is. Research is also looking into specific genetic mutations and sort of abnormalities in the immune system itself that might contribute. But yeah, likely a complex interplay.
Multifactorial, but EBV is a major player.
Okay.
That leads nicely into risk factors. Who's more likely to develop HL?
Well, we've just mentioned EBV infection, having had glandular fever or infectious mononucleosis, which is usually caused by EBV, is a known risk factor.
Right.
A family history of Hodgkin's lymphoma also slightly increases the risk.
Okay, so a genetic link there, potentially.
Potentially, yes. And having a weakened immune system is another key factor.
Weakened how?
This could be due to conditions like HIV infection or from taking immunosuppressant medications, perhaps after an organ transplant.
Makes sense. Immune system involvement.
Yeah. Certain genetic conditions like Down syndrome also seem to carry a slightly higher risk. And cigarette smoking is also implicated as a risk factor.
So EBV, family history, immunosuppression, prior mono smoking. quite a few things to consider.
Hmm.
Let's dig a bit deeper into the how, the pathophysiology, what's actually happening at the cellular level.
Okay, so it starts with those abnormal B lymphocytes, the ones that become Reed-Sternberg cells, developing within the lymph nodes. Crucially, these cells undergo genetic changes, mutations, and these mutations allow them to essentially hide from the immune system.
Like a cloaking device you mentioned earlier.
Exactly like that. They manage to evade the normal immune surveillance that would usually destroy abnormal cells.
Clever, but obviously problematic. What else do they do?
They don't just hide, they actively manipulate their environment. They release signaling molecules called cytokines.
Cytokines, inflammatory signals.
Yes, partly inflammatory. These cytokines trigger an inflammatory response within the lymph node, which is a big reason why the lymph nodes swell up that characteristic lymphadenopathy.
Ah, so the swelling isn't just the cancer cells, it's the reaction to them too.
Precisely. And these cytokines also act almost like growth factors, encouraging more malignant cell growth and changing the local tissue to make it more hospitable for the lymphoma.
So they evade, inflame, and recruit help.
You got it. And as these abnormal cells build up, they disrupt the normal structure and function of the lymph nodes and the lymphatic system overall.
Okay, that paints a clearer picture of the process. Now, thinking clinically, if someone presents with swollen lymph nodes, Hodgkin's is on the list. But what else should be? What's the differential diagnosis?
Ah, yes. Crucial for exams. The differential for enlarged lymph nodes, or lymphadenopathy, is broad.
I bet.
Top of the list, you'd have other lymphomas, particularly non-Hodgkin's lymphoma. They can present similarly.
Okay, other lymphomas. Makes sense.
Given the lymph node swelling
Mhm.
and the EBV link we discussed, infectious mononucleosis or glandular fever is a key differential, especially in younger people.
Right. Very important not to miss that.
Definitely. Then you have infections. Tuberculosis, TB, can cause lymph node enlargement.
TB. Okay.
Other infections like cytomegalovirus, CMV, or toxoplasmosis can also mimic it. Even things like tularemia, though rarer.
So a lot of infections.
Yes. And then non-infectious inflammatory conditions like sarcoidosis.
Sarcoidosis, right, can cause widespread lymph node issues.
It can. And don't forget other cancers. Leukemia can sometimes present with lymphadenopathy, myeloma less commonly, but possible. And in patients with HIV, you need to consider AIDS-related conditions.
That's a pretty wide list. How do you start narrowing it down?
You look at the whole picture, the patient's age, remember the bimodal peaks for HL. The specific symptoms are B symptoms present: fever, night sweats, weight loss. Those push you more towards lymphoma.
Right. B symptoms are a big clue.
And the characteristics of the lymph nodes themselves, the pattern of spread, other medical history,
Right.
it all feeds into the diagnostic process.
Okay, good approach. Let's talk numbers. How common is Hodgkin's lymphoma? What's the epidemiology look like, particularly in the UK?
Compared to all cancers or even all lymphomas, Hodgkin's is relatively rare.
Okay.
In the UK, we see around 1,800 new cases each year, something like that.
1,800 a year?
Yeah, and remember that bimodal incidence pattern. That's key epidemiologically. A peak in young adults, typically between 20 and 34.
Right.
And then another peak in older adults, often 75 and above.
So important for those age groups.
Definitely. The overall annual incidence rate in the UK is roughly 2.7 per 100,000 people.
Okay.
And as we mentioned, a slight tendency to affect males more often than females.
So relatively rare overall, but one of the more common lymphomas, especially hitting those young adult and older adult populations, slightly more males.
Got it.
That's the gist, yes.
Now let's get into the clinical side. What signs and symptoms should make you suspect Hodgkin's lymphoma? What are the classic clinical features?
Okay, this is really high-yield stuff. The B symptoms are probably the most famous.
These symptoms, right.
There's a handy mnemonic sometimes used. BFIT.
BFIT. Tell me more.
Okay, so B is for the B symptoms themselves, but you can break it down. F for fever, persistent unexplained fever, usually over 38 degrees Celsius. I for itchy skin pruritus, which can be quite severe. T for night sweats, often described as drenching. And then add unexplained weight loss, usually significant, like more than 10% of body weight over 6 months.
Okay, fever, itching, night sweats, weight loss. And fatigue is often mentioned too, right? Yes, fatigue is very common. So BFIT plus weight loss and fatigue, these systemic symptoms are crucial. Diagnosis is often prompted by these or just general malaise, lethargy.
Those B symptoms, fever, drenching night sweats, weight loss 10% in 6 months, are found in about 25% of patients. Is that right?
Roughly, yes. About a quarter of patients present with B symptoms, and their presence is important for staging and prognosis.
And what about physical signs? What might you find on examination?
The most common sign by far is lymphadenopathy, enlarged lymph nodes,
Where typically?
very often in the neck, the cervical region, or just above the collarbone, the supraclavicular area. The chest, the mediastinum, is also very commonly involved.
Okay, neck and chest are key areas.
Definitely. But you can also find enlarged nodes in the armpits, axillary or groin, inguinal, or really anywhere below the diaphragm, too.
And are these nodes usually sore?
Typically, no. They're usually described as painless or non-tender and often feel sort of rubbery.
Painless, rubbery nodes. Okay.
There is that one specific, though quite rare, symptom.
Hmm?
Some patients report pain in the enlarged lymph nodes after drinking alcohol.
Alcohol-induced nodal pain. Specific but rare, less than 10%. Got it.
Exactly. Other potential findings on examination could include hepatosplenomegaly, an enlarged liver or spleen.
Oh,
And depending on where the enlarged nodes are, especially if they're bulky in the chest, you might get symptoms like a persistent cough, shortness of breath, maybe from a pleural effusion, or even signs of airway obstruction or superior vena cava syndrome in rare cases.
right. Compression effects.
And occasionally you can see paraneoplastic syndromes, sometimes neurological ones like cerebellar degeneration or Guillain-Barré syndrome, but these are uncommon.
So the main things are painless lymphadenopathy, often cervical or mediastinal, and those B symptoms.
That's the core picture, yes.
Now, once you suspect HL, how do you confirm it and figure out how far it's spread? That's staging, right? Tell us about the Ann Arbor system.
Absolutely. Staging is critical for determining treatment and prognosis, and we use the Ann Arbor classification.
Okay. How does it work?
It's based on the location and number of involved lymph node regions, and whether it's spread outside the lymphatic system. There are 4 main stages, I to 4.
Stage 1.
Stage means involvement of just a single lymph node region or a single lymphatic structure like the spleen or thymus.
Okay, just one area. Stage 2.
Stage 2 involves 2 or more lymph node regions, but importantly, they're all on the same side of the diaphragm.
Same side of the diaphragm. Got it. Stage 3.
Stage 3 means there's lymph node involvement on both sides of the diaphragm, above and below.
Both sides. And stage 4.
Stage 4 indicates diffuse or disseminated involvement of 1 or more extralymphatic organs like the liver, bone marrow, lung, skin, with or without associated lymph node involvement. Basically, widespread disease outside the lymph system.
IT3, 4. Clear progression. What about the A, B, and E classifications?
Right. Each stage is further classified as A or B. A means the patient has no systemic symptoms. They're asymptomatic in that regard.
A for asymptomatic.
Exactly. B means the patient does have 1 or more of those B symptoms we discussed. Unexplained fever, 38 degrees C, drenching night sweats, or significant unexplained weight loss, 10% in 6 months.
B for B symptoms. And generally, B indicates a worse prognosis, right?
Generally, yes. Presence of B symptoms often points towards more aggressive disease or a greater disease burden.
And B.
E stands for extranodal involvement. It signifies involvement of a single extranodal site that's directly adjacent or contiguous to a known nodal site of disease. It doesn't automatically bump up the stage in all cases, but indicates local spread outside the node.
Okay, so Ann Arbor stage, IIV, with AB for symptoms and E for local extranodal spread. That's the framework.
That's the framework we use, yes.
So recapping the presentation, often that enlarged painless node, maybe a mediastinal mass found on X-ray, B symptoms in about a quarter, rarely alcohol-induced pain.
You've got it.
Okay, on to investigations. How do we nail the diagnosis and get all the staging information?
Well, the absolute cornerstone, the definitive test, is an excisional biopsy of an affected lymph node.
Excisional, meaning taking the whole node out.
Ideally, yes, or at least a substantial part. Needle biopsies can sometimes be suggestive, but an excisional biopsy gives the pathologist the best sample to see the architecture and find those Reed-Sternberg cells.
Biopsy is key for diagnosis. What next?
Imaging. Imaging is crucial for staging, figuring out exactly where the lymphoma is.
What kind of imaging?
CT scans, computed tomography of the neck, chest, abdomen, and pelvis are standard. But nowadays, PCT scans are very commonly used.
PTCT, positron emission tomography combined with CT.
Exactly. PET scans are very good at showing metabolically active areas, which lymphoma typically is, so they can pick up involved sites very effectively, often better than CT alone. PTCT is now the recommended standard for staging and also for assessing response to treatment.
Does PCT help avoid other tests?
It can do, yes. For instance, a negative PET scan in someone with early-stage disease might mean a bone marrow biopsy isn't necessary, whereas previously it might have been routine.
Okay, so biopsy for diagnosis, PTCC for staging. What about blood tests?
Blood tests are important too. A full blood count, or CBC, is
What
essential.
might that show?
It can show various things,
Yeah.
sometimes anemia, low red blood cells. You might see changes in white blood cells, maybe neutrophilia or eosinophilia, an increase in certain types, or sometimes lymphocytopenia, a decrease in lymphocytes. Platelets can sometimes be low too.
Any blood tests linked to prognosis?
Yes, an elevated erythrocyte sedimentation rate, the ESR, is often checked. A high ESR can be a poor prognostic factor. Same for low hemoglobin or low albumin levels. LDH, lactate dehydrogenase, levels are also checked. High LDH can indicate a higher tumor burden or poorer prognosis. Liver function tests, LFTs, are done as well.
So FBC, ESR, LDH, LFTs, albumin, all part of the workup. And bone marrow biopsy, still done.
It's done less routinely now thanks to PTCT, especially in early stages, but it's still often considered, particularly in patients with stage 3 or IV disease, or if they have B symptoms or unexplained blood count abnormalities, to definitively check for bone marrow involvement.
Okay, so biopsy, imaging, mainly PTCT, bloods, and sometimes bone marrow biopsy. That gives you the full picture.
That's the standard workup, yes.
Right. Now we have the diagnosis and stage. Let's talk management. How is Hodgkin's lymphoma treated?
Treatment is generally very effective, especially in earlier stages. The approach depends heavily on the stage of the disease, the patient's age, their overall health, and prognostic factors.
What are the main tools in the toolbox?
The mainstays are chemotherapy and radiation therapy. In some situations, targeted therapy might be used, and for relapsed or refractory disease, stem cell transplant is an important option.
Let's start with chemotherapy. It's often the core of treatment, isn't it?
It usually is, yes, especially for stages beyond the very earliest localized disease.
What are the common chemo regimens we should know for MSRA?
The classic and still very widely used regimen, especially in the UK and Europe for many cases, is ABVD.
ABVD. What does that stand for?
It's an acronym for the drugs used. Doxorubicin, also known as adriamycin, blamycin, vinblastine, and dicarbazine.
ABVD. Got it. Is that used for everyone?
It's very common for both early and advanced stages, often combined with radiation in early stages. For more advanced disease or cases deemed higher risk, sometimes more intensive regimens are considered, like B-cup.
B-cup. Sounds complex.
It is more intensive. Stands for bleomycin, etoposide, doxorubicin, adriamycin, cyclophosphamide, vincristine, oncovin, procarbazine, and prednisolone. It can be more effective for high-risk disease, but also carries more toxicity.
More potent, more side effects.
Essentially, yes. The choice depends on balancing efficacy and toxicity based on individual risk factors.
What about if the lymphoma comes back after initial treatment? Relapse.
For relapsed or refractory disease, the standard approach is often high-dose chemotherapy followed by an autologous stem cell transplant.
Using the patient's own stem cells.
Exactly. You collect their stem cells, give them very high doses of chemo to wipe out the remaining lymphoma, and then give the stem cells back to rescue their bone marrow.
A more aggressive approach for relapse.
Yes. And we need to remember side effects. Chemo can cause neutropenia, low white cells, increasing infection risk. So sometimes antibiotic prophylaxis or GCSF injections are used to boost white cell counts.
GCSF, granulocyte colony stimulating factor.
Right. And long-term risks include potential secondary cancers later in life, like leukemia or solid tumors.
Okay. What about radiation therapy? Where does that fit in?
Radiotherapy is often used, usually combined with chemotherapy, particularly for patients with early-stage disease, stage 1 or 2.
Combined modality treatment?
Yes. The idea is that chemo treats systemic disease, and the radiation targets the original sites of bulky disease or involved lymph node regions to reduce the risk of local relapse.
Is it always used in early stages?
Not always. Sometimes if a patient has bulky early-stage disease but achieves a complete remission after chemotherapy, particularly if the PE scan is negative, radiotherapy might be omitted to reduce long-term side effects. It's the evolving area.
What are the side effects of radiation we need to be aware of?
Short-term can include skin reactions and fatigue. Long-term, depending on the area treated, there's a risk of damage to nearby organs. Radiation to the neck can cause hypothyroidism, so thyroid function needs monitoring.
Thyroid checks.
Important. Radiation to the chest can increase the long-term risk of heart disease and secondary lung or breast cancers, especially if given at a young age.
So minimizing radiation exposure is a goal if possible.
Exactly.
Yeah.
Modern radiotherapy techniques are much better at targeting the lymphoma and sparing normal tissues. Also a practical point. Patients who've had radiation often need irradiated blood products if they ever need a transfusion to prevent a rare complication called transfusion-associated graft versus host disease.
Lifelong need for irradiated blood products. Good point.
Yeah,
So before starting any of this, what's the overall approach? Any pretreatment checks?
absolutely. Before starting treatment, you assess the patient thoroughly. Cardiac function tests like an ECG or echocardiogram and pulmonary function tests are important, especially if using drugs like doxorubicin or bleomycin, which can affect the heart or lungs.
Baseline checks.
Yes. If there's head and neck involvement, an ENT review might be useful. And critically, fertility preservation needs to be discussed with all patients of reproductive age, as chemotherapy can cause infertility.
Fertility counseling. Crucial.
Definitely. Men should be offered sperm banking, semen cryopreservation before starting chemo. Women should be referred to a fertility specialist to discuss options like egg or embryo freezing.
So a very holistic approach before treatment even begins.
It has to be. Then the specific therapy is tailored based on histology, stage, prognostic factors.
And after treatment, what does follow-up involve?
Follow-up is essential. Typically, patients have regular reviews, maybe every few months initially, then spacing out, for around 2 to 5 years after finishing first-line therapy.
What happens at these reviews?
Checking for any symptoms of relapse, monitoring for late effects of treatment, routine surveillance imaging, like PEE-3T scans, isn't usually recommended if the patient is well, as it hasn't been shown to improve outcomes and carries radiation exposure.
So clinical follow-up mainly, unless symptoms arise.
Generally, yes. But awareness of long-term risks is key. We mentioned the increased lifetime risk of second cancers, cardiovascular disease, pulmonary disease, and infertility.
So advice on managing those risks.
Yes, lifestyle advice is crucial. Stopping smoking is paramount, managing cardiovascular risk factors like blood pressure and cholesterol. Regular thyroid function checks for those who had neck radiation, and reminding them about the irradiated blood products need.
Okay, long-term surveillance and risk management makes sense. Let's talk prognosis. What's the general outlook?
Overall, the prognosis for Hodgkin's lymphoma is generally very good. It's considered one of the most curable cancers, especially when diagnosed in the earlier stages.
High cure rates. That's encouraging.
Definitely. Most patients, particularly younger ones with early-stage disease, achieve complete remission and long-term survival.
What factors influence the prognosis?
Several things. The stage of diagnosis is a major factor. Earlier stage means better prognosis. The presence or absence of those B symptoms is important.
Right. B symptoms are generally unfavorable.
Correct. Age is also a factor. Older patients tend to have a slightly worse prognosis. Certain blood results we mentioned, like high ESR, low albumin, low hemoglobin, low lymphocyte count, or high white blood count, can also indicate a poorer outlook. Male gender is sometimes listed as slightly less favorable, too. And, of course, how well the lymphoma responds to the initial treatment is critical.
So a combination of stage, symptoms, age, and lab markers helps predict the outcome.
Yes, these factors are often combined into prognostic scores to help guide treatment intensity.
And the long-term prognosis, even for survivors.
While cure rates are high, long-term survivors do have an increased mortality rate compared to the general population.
Why is that?
In the first, say, 5 to 10 years, the main cause of excess mortality is still the Hodgkin's lymphoma itself, especially for those who had poor prognostic features or relapsed.
Oh.
But later on, say after 20 years or more, the increased mortality is largely due to the late effects of treatment.
Those secondary cancers and cardiovascular issues we discussed?
Exactly. Neoplasms, cardiac disease, pulmonary disease, and sometimes infections contribute significantly to late mortality. It really highlights the importance of minimizing treatment toxicity where possible and long-term follow-up.
A critical balance. Cure the disease, but minimize the long-term costs.
That's the challenge, yes.
Finally, let's summarize the potential complications associated with HL and its treatment.
Okay. Key complications include relapse or recurrence of the lymphoma itself.
Right.
The late effects of treatment, which we've covered quite a bit, secondary malignancies, cardiovascular disease, lung problems, infertility, hypothyroidism, and immune system suppression, both from the disease and the treatment, which increases the risk of infections.
Can we quickly recap those secondary malignancies again? They seem quite significant.
They are. There's an increased risk of leukemia, especially acute myeloid leukemia, AML, after chemo or combined therapy.
Okay.
And various secondary solid tumors, often related to radiation fields. Cancers of the colon, lung, bone, breast, thyroid are all seen more frequently.
Breast cancer risk is particularly high for young women receiving chest radiation, isn't it?
Yes, very much so, especially if radiation was given during adolescence or young adulthood when the breast tissue is developing.
Yeah.
That requires specific long-term screening.
Okay. Any others?
There's also data suggesting increased risks of melanoma, non-Hodgkin's lymphoma developing later, soft tissue sarcomas, and cancers of the salivary gland and pancreas. It's quite a broad range of potential long-term risks.
So surviving HL is often just the first step. Managing the long-term consequences is vital.
Absolutely fatal.
Wow, okay, that covers a huge amount of ground on Hodgkin's lymphoma. A complex condition, definitely, but as you said, often very treatable, particularly now.
That's the key message. It's treatable, often curable, but understanding the nuances, the diagnosis with Reed-Sternberg cells, the staging, the treatment options like ABVD, the B symptoms, and those long-term effects is crucial for MSRA success.
Absolutely. Getting your head around those different aspects we've discussed today will really help consolidate your revision.
Hopefully this deep dive has given you a solid framework.
I think so. And for everyone listening, to really test your knowledge and find more fantastic resources for your MSRA prep, do check out passthemsra.com.
And don't forget freemsray.com for additional questions and materials. Both are excellent resources.
Definitely worth exploring. Keep up the hard work with your revision.
Yes, focus on these key areas, and best of luck with the MSRA and your future medical careers.
Thanks for diving deep with us today. Until next time, keep learning.